sorry for that. So this one, again, apologies in advance, it's a little bit of a dry lecture, but it's one of those things that we really, really need to get this basics around our head, and then essentially we can do whatever we want with imaging. So Ben's explained what's normal, and the use that we can take out of X-raying, but you need to know how to physically actually acquire them and how to acquire good X-rays. The reason for that, how many dimensions does X-ray have as a modality? How many dimension pictures does it generate? Is it 2D? Is it 3D? 2D, exactly. So, if you think of a cube, and you take an X-ray of this bit here, you have your cassette underneath it. How is this going to show up as a picture? You're essentially going to get a picture that is a square. And that doesn't give you nowhere near enough of an idea of what your structure actually has. There's going to be overimposition of all of this behind it, and that's why you need to change your positioning constantly to highlight different bits of what you want to image. So, X-ray positioning, and I'm afraid this is a little bit of an instruction guide of how to acquire them, but you don't need to necessarily remember all of this, it's just understanding how it works. Things to remember. As Ben mentioned in the first lecture, it's about the positioning, and there's a lot more to the technique as well. So you need to have the correct equipment, the correct settings, which Ben has already spoken about. You need to have your patient still, and your operator still, and your plate still, so everyone holds their breath to take an X-ray. You need to make sure that the distances are correct. It's the same thing as a projector. If you get too close, you might overexpose your patient, you're going to diminish the size that you're actually acquiring an image of. If you get too far, you're not getting enough exposure through that, and you're going to have your collimation settings all wrong as well. Other important things to remember is to remember what is radiolucent and what is radio-opaque. So Ben showed a picture earlier of the horse being X-rayed through a bandage, which we do very, very often in equine practice because they will normally have a bandage for a reason. If it's protected, if you suspect a fracture, so you don't want to necessarily take off that bandage to be able to see the bone, but that's fine because what's in that bandage, so all your cotton wool and all of that, is radiolucent, so that allows the X-rays to penetrate and give you the image of the radio-opaque structures, which in this case would be your bones. However, if you want to X-ray a foot, for example, a foot of a horse or a foot of a donkey, you might have to remove some of the radio-opaque structures that might cast a complete shadow over the anatomy that you're actually wanting to look at. And this would be things like, for example, taking the shoes off, if that gets sort of overimposed on some of your pictures, and we'll see some examples later. You might not always have to do this. You might not always want to do this if what you want to look at is how your shoe relates to your anatomy and if it's adequate or not. But you might have to think about that. Also, if you're trying to image the head, remember, the buckles and all of things of a head collar might sometimes have metal, and that again is going to cast a shadow, so it's going to effectively hide some things. So you need to think of all these baseline things, and then you must prepare your patient. So, like Ben showed in the first lecture, if you want to image a limb that's covered with dried mud and all sorts of things, at the end of the day, when you get an image with all sorts of different structures of different lucencies, you don't really know if that's a bone fragment, if it's a little bit of solidified mud that shows up on X-ray. So you need to make sure you eliminate all of those things to then objectively interpret your image and take adequate conclusions of it without being fooled. You must also check your exposures and make sure everything else is correct, and obviously think of radioactive safety as well, and think about your gowns and your distances and unnecessary exposure of unnecessary people. Patient preparation, so like we said, remove all dirt or radio-opaque materials just so you're not hiding any of the important anatomy. particularly in the foot. Ben has again mentioned this already, so I'll just go over it very, very quickly, but the foot has obviously lots of crevices. I mean, the frog holds a lot of dirt and pebbles and mud and all sorts. So if you're really worried about some subtle changes in the foot that you really want to investigate accurately, so make your life easy. Clean the foot, take all the gross dirt out of it. You might have to pare the foot with a hoof knife, because if the hoof is dry enough and overgrown enough, you get these crevices with air, and then air is radiolucent on X-ray, therefore it might fool you as being some sort of fracture line or something along those lines, and you just want to make your life as easy as possible to avoid all possible artifacts. And then again, think about the exposure of whatever you're going to image. And again, this is equipment specific, and I, for example, I certainly do not know these by head. I don't see a reason why you should have to know these by memory. You can always consult the manual, but all you need to understand is the principles of how they are applied and what they change or not, like Ben said, and adjusting the clarity of the structures of the KVs and the exposure and the quantity of radiation going through per second, so you wear maze essentially, and then understanding what increasing or decreasing each of them will produce, and therefore you can adjust if you're not happy with your results. So, moving on to actually positioning, there's all sorts of assistance that you can use for your positioning. You can use someone, well, you will need to use someone to hold the animal, but then you can make your life easier as well. So if you want to use any of these blocks, for example, has anyone seen any of these to x-ray the foot of a horse? Exactly, so you can make a horse stand on them instead of having to hold the leg necessarily on a still position, because remember, you have to be as still as possible. So if you have something where the horse can put some weight on, that just makes your life easier. But equally, and we'll talk about this a bit later, you don't necessarily need to just depend on the blocks. You need to understand the principles, understand the positioning that you want to achieve, and then if you're caught unaware but happen to have an x-ray with you in the middle of nowhere, and you can always improvise and figure out other ways of doing this without the actual block. So don't be too dependent on them, but be aware what they can do for you and how they might help you. Essentially, why we use a normal block in the foot, so a solid block like this, we make the horse stand on the block because we want, as Ben said, on our collimation and on our inclusion of our radiograph, we want to include every single bit of that foot to make sure that we didn't miss out the very edge of it where the problem might be. And obviously, if the foot is on the ground, your machine cannot include lower down enough on the ground to include the whole of the sole and evaluate things like foot balance and so on. So you might want to just raise that, make your life easier, make the horse step on a block, and then you know that you can get to the very bottom of the block. Grids. This is not so much applicable for common equine practice. So grids, basically, they just filter a lot of the scatter radiation and make you put it sort of in front of a cassette, and it just filters a lot of the rubbish radiation that you don't want when you need to use very, very high exposures. But having said that, in our sort of working animal medicine, certainly with horses, you don't use this often enough. You use this in specialized hospitals that have powerful enough generators to x-ray backs and to x-ray necks. But normally, and the normal portable machines that you see in the field don't even generate those powers that would then require a grid. But it's important to know they exist as well, should you end up needing them at some point. And then also always considering the distance. And again, this will be specific to the equipment. Most, and it will tell you on the x-ray equipment, depending on the brand and on the make and all of that, but normally between sort of 60 to 70 centimeters, or in some structures and in some systems up to 1 meter, that would be a rough idea. So you don't want to be, glued to the animal with the generation very close to the animal, the generator, but you don't want to be 2 meters away. You need to have this optimal distance, and you can always consult what it is depending on which equipment you have. And then you need to think of your anatomy. Anatomy, and unfortunately anatomy and imaging really do go hand in hand. So you need to think of your terminology and about the planes, and it's all this drawing about where you would cut a structure and what you would see, converting something that is 3D into 2 dimensions. And to make life easier, we think about all these different planes in an animal. So we have the dorsal, and you can think the dorsal as the dorsum as the back, so that would be your dorsal aspect, and the ventral as the belly as the ventrum. So this would be dorsal aspect, ventral aspect. On the lower limbs, this actually changes name just to make life difficult. So you would have dorsal aspect still on sort of the front, so to speak, of your limbs, where you have all your extensor tendons, for example. But then the lower part of your limbs would actually be called palmar for the forelimbs and plantar for the hind limbs. And in terms of direction, longitudinal direction, you have cranial, if it's towards the cranium of the animal, and you have caudal, if it's towards the back of the animal. It's actually the head, again, just to make life difficult, this changes again, and it's rostral if it's towards the nose, but then caudal again if it's towards the bottom of the head. And you can essentially apply these terms to everything that you image, and then you have the very important lateral and medial. So in a leg, for example, this would be medial, which is towards the surface here, and this surface here, which is towards the middle of the legs, whereas lateral is towards the sides. And this is important to be able to describe, and because a lot of actually the names of the projections and so on derive from knowing these basic planes. The main ones we use for X-ray, and the main terms and directions we use, are the lateromedial view. So this again, all you need to do is think about the name of the projection, and that will tell you exactly what it does. So a lateral medial view means that it is projected from the lateral side onto the medial side. You have your projector on the lateral side of the leg that you want to image, for example, and you have your cassette on the medial side. And that gives you a lateral medial view. Equally, a dorsopalmar or dorsoplantar view will be projected from the dorsal aspect. So in this case, I'd have my generator here, and I will put my cassette here, just behind the leg, and I would have a dorsopalmar or dorsoplantar view. And then in terms of the distal limb imaging positioning, which is what we're going to talk about in this lecture, we have two rather basic ones, which are this rather long name, dorsolateral palmaral or plantaromedial oblique, and the dorsomedial palmaral plantarolateral oblique. It's a mouthful, that's why we shorten it to DLPMO or DMPLO. But again, it actually helps, or it used to help me actually, to say the long name and deconstruct it, because it just tells me the direction of my beam. So if I have a dorsolateral palmaromedial oblique, that means that my beam, my X-ray beam, is going to travel in between the dorsal and the lateral, and is going to land in between the palmar and the medial. And there it is, the name says it all. And again, this is a bit more simplified, but we're talking cranial, caudal, dorsal, ventral, proximal if it's sort of up the limb, distal if it's down the limb, and in the head, the same thing. Right, so very basic positionings for the distal limb. And I'm just going to talk about the distal limb on this one because, as Ben mentioned, in equine medicine, if you're looking at donkeys or horses, and certainly in working animals, lameness is incredibly relevant, and it's very, very prevalent. So you will find that if you ever end up in equine practice, you will be predominantly imaging the limbs in terms of X-ray. Doesn't mean that that's all you can do, and we'll cover that later, but this will be a very big part of what you do, because that's where most of the pathology will be in terms of lameness. So, basic views of the foot, and the foot is a little bit of a lonely fish. It's a little bit different than the rest of the limb, so I'll talk about the foot separately, and then I'll just talk about the rest of the limb. Basic view number one, so that would be a lateral medial view, and this is the same for the forelimb and the hind limb. And ideally, the foot must be raised on a block. Why? Because, like we said, if this is the square of light that your projector gives you, and if your foot is on the floor, you might just not get low enough to include all of the sole and to include a complete picture of your foot. So you raise it, and that overcomes that problem. Sometimes the animal's a lot more comfortable if he has both legs raised, instead of just sort of crookedly standing on one block and not on the other. So you can always do that, particularly if you want to look at foot balance. So if you want to look at how well trimmed or not the feet are, then you're actually distorting a little bit of the anatomy if you only put the animal on one block. So think about those things, step them on both blocks, and then off you go. And in terms of obtaining the view, you need to have X-ray vision in these cases and sort of imagine your anatomy inside the leg. So you see P3, P2, P1, and you want to image this joint here, which is the coffin joint, so between phalanx number 2 and phalanx number 3. And you ideally want to cut the joint. If you're looking at any irregularities or arthritis or any fragment, you want to be able to see that whole joint surface as clearly as possible. And so it's important that it's not oblique and having some bone on top of the joint space. So you ideally want to see this space as clear as possible. And that's why the accuracy of positioning becomes relevant, just because it allows you to actually see the structures that you're aiming for. So for this view, you want to center, aiming for where the level of P3 is, which is normally 1 or 2 centimeters down. And this depends very much on the conformation of your horse or of your donkey. It depends on how long its hoof is, so that's why you need to imagine the anatomy inside the hoof capsule. But you center just below the coronary band, and then you align with the heel bulbs just to try to get a true lateral as much as possible, and you should have the cassette on the floor, vertical and perpendicular to the floor, and that's how you project it. So this is a bit easier to see in this instance, so you can see the foot is in the block, you aim for just below the coronary band, you make sure you include the toe. This is a very common error. You chop off a little bit of the toe, include the heels, have the plate vertical underneath it, and then you should have a nice one like this, and you can see that the joint is actually perfectly open. There's not much bone overimposed there, so you can assess this joint now objectively. So that's your lateromedial view. I'm shooting from the lateral side onto the medial side. Another one of the routine series of the foot would be the dorsoplantar or dorsopalmar view. It just depends on whether we're talking about a forelimb or a hind limb. And again, this depends a little bit on what you do. You normally use this mainly for sort of foot balance and evaluating how it is, because it's not the best one to pick up pathology on P3. We'll talk about that one later. But your foot must be fully weight-bearing, because if the animal is leaning, then you don't know whether that's a true distortion of the anatomy, or if it's just the animal and therefore an artifact. You can center, so again, below the coronary band. This time the cassette is placed on the floor, but behind the animal, so on your palmar or plantar aspect, and the beam needs to be directed from the front of the animal vertically to horizontally, to behind of the animal. If you're doing hind limbs, you might be doing the opposite. So you can shoot, if you think about this image, the rays are going this way, so the radiation is cutting the joint across this way. You can equally, if it's safer and more convenient to do so, you can put the cassette here and project from here, because ultimately that will still give you the 2-dimensional same plane as it would otherwise. And you center just below the coronary band, and this is roughly how it should look like. So you can see if this animal, for example, was badly trimmed and had a lot of hoof on either the lateral or the medial side, you'd be able to evaluate that, and that's why it's important to have the block so you can see the entirety of the hoof capsule as well as your bone structures. And then we use this one very commonly as well. So it actually has in reality a longer name than here, but I've just shortened it to dorsoproximal palmarodistal oblique. And again, it sounds like a mouthful, but if you think about what it says, so you're shooting from proximally, so higher up on the dorsal aspect, and you're landing your beam palmar and distally. So it's sort of a diagonal one. You shoot from proximal and from dorsal, and you land palmarly and distal. However, because this is kind of tricky to do it diagonal like that, instead of moving the beam in that direction, you move the foot and create yourself the same angle. And you can do this at an approximately 45-degree angle or approximately 60-degree angle. It's just slightly different projections. But this is how it would look like, and this would be an instance where we would use one of those blocks. So we just position the foot conveniently on the block, and then we don't need to try to think of where we can place the cassette and do this diagonally and all sorts. Just much easier. We still do it vertically on a block that the block itself is making the coronary, is making the dorsal hoof wall at a 45-degree angle or a 60-degree angle. And then the cassette should be vertically behind, like this. And the image that you would get is this, which is actually a much, much better image to evaluate the third phalanx compared to the previous one that I showed you that is just a plain dorsal palmar. So you can see, this allows you to see all the margins around, you can pick up fractures and all of that. You miss a lot of the second phalanx because that is overimposed, because what you're trying to do here is highlight the third one. So the shorter name for this is upright pedal, because we're putting our pedal bone upright, essentially, to get the shot. But, like I say, this is the exact same thing as doing it this way. So in this case, you'd have the cassette on the floor, and you would have your camera doing this view instead. For this, you need a block like this, which is called a tunnel block, which essentially is a wooden case in which you stick in the cassette, and that protects it from being obviously trodden on by the animal, and then you obtain the same view. But essentially, you're still cutting the foot at the same 45 or 60 degree angle. So it's the exact same thing, and this is what I mean about creativity. If you don't have an upright pedal block, don't panic. Just you understand what the view is, how you need to obtain it, and you can figure out another way of doing it. And you can use this same projection with centering and collimating at different levels to focus either on the third phalanx, like we've spoken about, or you can narrow your collimation, change the settings, and focus on your navicular bone, which is overimposed, but it's all here nonetheless. So this is one of the views as well that you can use for the navicular bone. And like I said, in the hind feet, this is the exact same view, but done in a slightly more practical and safe way. So be aware that essentially what it's doing is cutting that structure in a certain plane, and you can recreate that plane in various ways. You don't need to stick necessarily to the guide. Right, and then these would be essentially your routine views. So your lateral medials, your dorsal palmars, your upright pedals. But you can essentially do 500 other views if you wish to. You can change your angle slightly, so to oblique, to highlight different parts of your anatomy. If you want to look at a wing like here, and if you want to look at possible fractured wing, if you just look at it from the front, you might miss it because it's just overimposed in a lot of things. So you can just change your angle, make it highlight, make it come out on the plate. You can do these fancy views, which are just called the skyline navicular views, which normally we use for show jumpers, competition horses, dressage, that would have pathology on the navicular bones. It's just highlighting a different plane of your structure. And this is why knowing your anatomy is important, and then you can just be creative. And who says 30 degrees can say 40 degrees, can say 51 degrees, if that's what's going to make your optimal image for that case. Right, so that's the foot. And then the rest of your distal limb, you can essentially apply the same principles, which makes it much easier. So you have 4 routine views for the rest of your distal limb. You have the dorsal palmar, or dorsal plantar, like we've spoken about, which cuts from the very front to the back of the structure. The lateral medial, so from the side to the middle. And these on themselves make a 90-degree angle. And then the other 2 that you should always do as a basic routine examination of any structure of the distal limb would be the other 2 that we've already spoken about. So the dorsal lateral palmar medial oblique and the dorsal medial palmar lateral oblique. So the DLPMO and the DMPLO. And you can see here they essentially go in between the dorsal and the lateral for the DLPMO and land exactly the opposite way. And this one starts in between. Even the computer's getting bored, I'm sorry. Right, so this one, the projection is in between the dorsal aspect and the medial aspect, so it's shot from here and lands the opposite way. You can see it here. It essentially applies to every structure from the foot up. And what this does is it essentially highlights all the structures all around, bringing into relevance different hidden points that might be overimposed on the 2 standard lateral medial LEPs. So, for example, I've actually on the break I was drawing this little. What is this beautiful drawing of? Any suggestions?
Head.
Fail. Yeah. Fetlock, exactly. And what view might this be? Exactly. So this is the lateral medial of the fetlock. So you have your first phalanx and your metacarpus or your metatarsus, and these 2 are the sesamoid bones. And in this view, you're looking at the joint space. So this is beautifully open. You can look for any pathology, any away, any little fragments. Great. But what if I wanted to look at a sesamoid bone? I essentially see a nice sesamoid bone, but what this represents is the two sesamoid bones overimposed on each other. So what if my fracture or my problem was actually on this lower one, and it's a little thing here that's just going to be overimposed by the one that's in front of it? How can I highlight that? That's why it's important if you rotate it in such a way that when you have the cassette behind it and you project the whole image, you can hide one sesamoid away, for example, behind it, so it doesn't matter, I'm looking at this one now, but this one gets completely free of overimposition, which allows me to objectively assess the whole margins of this. And this essentially is what we're looking for, is looking at all the angles, looking at all the sides of the cube and seeing where the problem is. And so again, this is actually, if we look at the cannon bone, for example, with the two splint bones, so if this is a leg of a horse or a donkey, and we look at it from the top, so this would be a transverse projection. If we highlight the different bits, you can picture it a bit easier now, what you would be highlighting on each. So if I'm projecting from here, all my rays would be going this direction. This one is hidden by the big bone, but actually this one is left out. So I'm actually making my life easier to assess any problem in here. Whereas if I take this view, all the parallel rays are going this direction, so this one will be hidden underneath the big bone, but this is now free for me to evaluate. And that's the principle basically, and it's very easy. You can see in here, so this is how you would take it. You essentially rotate 45 degrees, and then it highlights different structures. So I'm highlighting this splint now, highlighting the other splint, this one actually, and that's how you go about making sure that you're imaging the whole structure through your two-dimension method. So, for the fetlock, for example, and again this applies to the other joints, the four basic views that you would want to do would be a lateral medial, and then you just walk 45 degrees on each direction until you have all the four. So, lateral medial, dorsolateral palmar or medial oblique, DP, so dorsopalmar, and dorsomedial palmar lateral oblique. And then there's little tricks and little variations just because it can be this easy. So, to get a true lateral normally, you would have to go just a touch behind the patient, just because that's where it's going to cut the joint pace open the best, really. But this comes with experience, this comes with doing lots of them, and it comes with looking at the screen and saying, oh, I'm not actually cutting the joint perfectly well through here, so I need to change my position just a touch to the left or just a touch to the right, and that learning comes with experience, so don't worry too much about it. But most importantly, you need to look at your patient and the conformation of your patient. So if your animal is with his legs completely toed out, for example, you're not going to stand 45 degrees from the body of the animal on the side that is that angle. You need to adjust. You need to follow that limb that is actually pointing outwards to try to cut the joint at a level that will be actually perpendicular to it and that will give you a good image. So always adapt to your patient. This is how you would get a lateral medial, and this is how it should look nicely with a joint space. But as you can see, the sesamoids, I can't tell what is what, where my problem is, so I need to open them up to distinguish between them. And then there's other subtleties. For example, dorsopalmar, dorsoplantar of the fetlock, the principle is the same, so your beam projection is from the dorsal aspect to the palmar or plantar aspect, but you don't necessarily want to be perpendicular to the floor. You want to be perpendicular to the joint. And as you know, the legs of a horse or a donkey are not themselves perpendicular to the floor. So you just need to be, instead of being perpendicular to the floor, you need to be perpendicular to the axis of the leg. And that's, again, just adapting to the anatomy of the animal. And this is how it should be. And the reason why we also make this inclination and this angulation with the beam is because if we want to look at the joint space, we need to have these guys out of the way. So by angling down, it brings the sesamoids a little bit up, which makes life easy to look at the joint space itself, which is where most pathology would be that we're looking for. And again, the DLPMO and the DMPLO are just rotating in between those two standard views, and you can see how you highlight one and the other one is overimposed, and the opposite view would highlight the other one. And, I mean, the sesamoids are just an easy example to explain, but you obviously highlight the whole other component. You know, you highlight this bit of the joint. What if I have a little chip here hiding away that I couldn't spot in any other projection, for example? So it applies to the whole structure. And the same with the other one. And with, just wanted to mention something, with these dorsomedial views, so the ones that are in between the dorsal aspect and the medial aspect, often, particularly in the hind limbs, it means that your projector kind of needs to be underneath the horse, and if it's a foal or if it's a donkey or a small animal, it's dangerous and it's fiddly. So you can do, and sometimes it's not as nice, but if you need to do it that way, you can do the opposite. So you can shoot from behind and just have the plate here with a holder that makes life much easier and safer for everyone else. The projection is ultimately the same. It's cutting the limb through the same plane. And then, this is the fun bit where you can just do other views. Because if you think about your lateral medial, there's many slides, sorry. Here. What the amount of, say, the metacarpus or the metatarsus that it allows you to see, you can't really evaluate the bone surface that's hiding on the actual joint. So you can do, for example, the flexed view. You can open up a lot more of that joint and look at other bits of the condyle that you could otherwise not see. So, for example, you can see how that differs. And so, again, you can explore. You need to know what you're looking for, where you might be looking for it, and then try to come up with a view that will show that the best. Again, for the pastern, same routine views. There's no point going through them. It's just rotating 45 degrees on each. And again, for the knee and for the hock, so for the carpus and for the hocks, same principles apply. Only difference, just so you don't get frustrated when you're practicing, for the carpi and for the tarsi, so for the knees and for the hocks, normally to get a true lateral, you might have to angle it down a little bit. That just has to do with anatomy, but just try that, otherwise you might get very frustrated. This happened to me very often. And again, you can do flex views, which will just open up your joint spaces and allow you to look at parts of the anatomy that are not obvious on a lateral medial view, as you can see here. So if you're looking for little fragments or slab fractures, for example, you can do that. The same way that you can do what we call skylining the structure. So shooting, making it in evidence, just the surface by shooting from above. And you can see like these people are doing here. So what you're doing in this is highlighting, depending on the angle that you use, highlighting different rows of the carpal bone, which might just be what you need to pick up some fractures, or if the animal falls on their knees, or racehorses get slab fractures a lot, for example, and you might just need to do one of these funky views to highlight it. But otherwise, the principles apply. Again, you can skyline the calcaneus. If you think there might be a problem here, you can just look at it from above so that you can see the margins of it. And this is taking it actually from the side, so this is a flex lateral, but you're taking it from the side as opposed to taking from the top. So be creative, and you can use all of these to your advantage. Stifle joint is a bit more tricky. You need other sorts of exposure, but normally the routine views would only just be a quarter crane, where you can pick stuff like this, so little cysts forming up in here as well, or a lateral medial, where you can look at the rest of the joint like that. And then, just to finish up before you all completely go to sleep, think about your patient, think about your anatomy. So like I said, you want to cut your structure. You want to, if you're looking at a joint, you want to be able to, the rays to penetrate that joint as through that joint as possible without any overimposition. And that changes according to the anatomy of the animal. Very evidently, it changes, for example, between horses and donkeys. If you look here, how different is this? I mean, if you're going to take the exact same landmarks of centering 1 centimeter below the coronary band, it might not work for that patient, because this donkey has a lot more hoof than this horse here, and than many other horses, for example. The same if you're trying to, if the joint space is like this on a horse that is very flat-footed, I think I have it on this side, exactly. So if you're actually trying to image this This will be a lot closer to the ground because your joint will be in this direction, whereas a donkey, they're naturally a lot more upright, so their anatomy will be different. And your point needs to be to try to adjust it and make it a lot more perpendicular to the actual floor, because the axis of the leg itself will be more perpendicular to the axis of the floor. Normally it's flexing and adjusting by about 5 and 10 degrees more upright. But you just need to be aware of this. Are there normal variations, particularly in the foot? Donkeys, their coffin bones, so their third phalanx, they're naturally further down in the hoof capsule. So, for example, with horses, the proximal extensor process of this P3 of the coffin bone normally roughly aligns with the level of the coronary band. And actually, do you know of a disease that we can use this as a measurement? Laminitis, does it ring a bell? Exactly. So in laminitis, we would actually look at sinking. We would look at rotation of P3, but we'd also look at the sinking of P3 within the hoof capsule. Because in a normal horse, it should roughly line up with the coronary band. However, in a donkey, if we're looking for laminitis, the donkey would be overwhelmed by the prevalence of the disease, because naturally the third phalanx sits much lower down the actual hoof capsule. That's normally over a centimetre, it's about 12 to 16 millimetres below, and this is normal. This does not mean that it is sinking, that it's normal. So we need to know these little subtleties so that we don't go off diagnosing laminitis, for example, in every single donkey. And that's it, really. And so remember to adjust here. You can see as well the axis, so your hoof pastern axis, and how more upright it is compared to a horse that's a bit more bent in here, and therefore you need to adjust your X-ray beam to cut through this pastern joint, the coffin joint, accordingly. So just to wrap it up, know the concepts of it and know what you're trying to achieve. That is the main thing. And then you can be creative and adjust to whoever you might be presented it. And then just remember little other things just for completion. So labeling, you might forget the following month if you x-ray the left or the right leg. The position of your labels in the actual cassette might help you identify the lateral and the medial side, exposure, collimation, and keeping everyone very still. And that's it. Thank you very much for listening. Any questions?
Just out of interest, do you think things like liquid can have maybe an effect on an image, or say maybe if I take an image and the weight bearing thing,
What, between taking the same projection in a weight-bearing limb and a non-weight-bearing limb? Yes, because if you're taking, so for example, an animal that's very lame and is not fully putting the foot down, for example, or sorry, I'm not sure I understand the question.
I'm saying, do you think weight bearing is an effect in the quality of the type of things that you were seeing in the
Yeah. I think so, yes, because it makes you more in control of your positioning. It makes you more in control of your movement. So if the animal is with 4 legs solidly on the floor, then you know that it's less likely to move and to tremor, and so that reduces artifacts. And also you know it's easier to reference your projections accordingly. If you have a leg that's roughly up in the air, then you kind of lose your dorsal and your medial and your angle, so it's nice. It's not to say that it's impossible, and sometimes we have to x-ray animals that are not weight-bearing because either they're too painful, or there's other reasons that we can't put that limb on the floor, and we just need to make do. But in an ideal scenario, you would have them weight-bearing for the routine views, unless you're specifically looking for the flexed views and the ones that you want to highlight other parts of the anatomy. Good. It's lunchtime.
Should we back at 1:45, 1:45 even, sorry?
Everyone okay with coming back at 1:45, 1:45? Yeah? Perfect. Have a good lunch then. Okay.